In this episode, I am once again joined by Dr. Chencho Dorji, Bhutan's first psychiatrist and the Professor of Psychiatry at Khesar Gyalpo University of Medical Sciences in Bhutan. Dr. Dorji reveals the challenges he faced establishing modern psychiatry in Bhutan, a culture heavily invested in a supernatural model of mental illness. He recounts stories of treating patients possessed by ghosts, local avatars of Shiva, reincarnations of Padmasambhava, and more. Dr. Dorji explains the role of religion and superstition in stigmatizing mental illness and considers whether shamanistic rituals and other traditional healing methods can coexist with modern medical practices. Dr. Dorji also warns that mental illness in general, and borderline personality disorder in particular, is on the rise in Bhutan, and shares his vision for a greater collaboration between modern medicine, the clergy, shamans, and Sowa Rigpa healers. So without further ado, Dr. Chencho Dorji. Dr. Chencho Dorji, welcome back to the podcast.
Good morning, Steve. Nice to be back.
I'm so happy to talk to you again. The first episode was very well received indeed. We covered your life. We talked about very difficult circumstances of your upbringing and a lot of suffering in your family, and how that suffering and difficulty inspired and motivated your decision to train in psychiatry. And in fact, that training itself was not without incident, and you faced many challenges there, which you overcame. And we also saw you complete postgraduate psychiatric training in Sri Lanka, and then clinical placements in Australia. That was what we covered in the most part. We hinted at certain themes that I'd like us to expand on today, which is the meeting and the tension between modern psychiatric approaches to mental health and traditional Buddhist, Bhutanese approaches, Sowa Rigpa, that sort of thing, shamanic, and so on. But perhaps first we can begin with after your Australia residency. So you were there for clinical placement for 1 year, after which time I believe you returned to Bhutan and began then to establish psychiatry there to some capacity. So what happened after Australia when you returned to Bhutan?
It was the year 1999. And again, it was one of those landmarks in the Bhutanese history when the fourth king of Bhutan announced in the country. It was also his silver jubilee year. He has been the king on the throne for more than 25 years, and Bhutan was celebrating his silver jubilee on the throne. And he made this pronouncement that from 1999 onwards, Bhutan will have television and mobile technology. So I actually came back right at that crux of the moment when there was significant modernization happening in Bhutan. So when I returned home, there was already one Burmese psychiatrist practicing there in the big hospital in Thimphu, to my surprise, rather. But yes, the WHO had actually fielded one consultant Burmese psychiatrist to work in Bhutan for 2 years in the years 1997 and 98. And after he completed, another Burmese filled in his place. So one doctor was already there, and I was pleasantly surprised to see him there. Unfortunately, the Burmese psychiatrist was not well trained in Burma. They had only 1.5 years of exposure post MBBS degrees. But of course, he was an experienced psychiatrist in Burma, but he was, of course, going through some trouble, challenges of the language and the culture of Bhutan. Although he did speak good English, but most of the Bhutanese didn't speak English. And some spoke very sophisticated English that was difficult for him to understand. So I was very happy that at least somebody was there, that I didn't have to really start from scratch. So the psychiatry was provided from a one-room outpatient sort of a clinic in the main hospital in Thimphu. And I joined him, and we were stationed together in the same room. But as fate would have to say, or I would call it karma, or coincidentally, the same professor that I worked with in Nimhans, Bangalore, back in 1988, he happened to visit Bhutan at the same time I returned and joined work in Bhutan. He was sent by the WHO again as a consultant, a short-term consultant, to review the situation in Bhutan on mental health and also to train some of the local doctors on mental health management. So this was a very auspicious moment for me, for the mental health service in Bhutan, and also for the professor to meet me in Bhutan again, this time as a psychiatrist. He was rather pleasantly surprised that I have become a psychiatrist after a long while. So two of us, we got down together and we devised what we would consider as the first training of our primary healthcare doctors on mental health management in Bhutan. So I'll call it auspicious because I always thought that when I came back to Bhutan, that we should start on what is known as community-based mental health services, rather than start a large mental hospital and provide services from there. In fact, the Burmese doctor who came in 1997, Dr. U Thuta, he actually advised the government of Bhutan to build a 200-bed mental health hospital in the center of Bhutan, in Bumthang. You have visited the place, Steve. And when the fourth king reviewed the 5-year plan in 1998, he asked the health officials, why did you have to build such a large mental hospital in Bumthang? Is it because Bumthang is the central part of Bhutan that people can come from both directions? Or is it because Bumthang is a very spiritual place that mental ill people will get well naturally because of the environment? The health officials, of course, did not have an answer because it was not of their initiative, but it was suggested by this Burmese doctor who has already left Bhutan by then. The fourth king, in his wisdom, actually even questioned, do we really need such a big hospital in Bhutan, knowing that we are a small society and our people are generally quite well in terms of mental well-being? However, this proposal was put in the so-called the eighth 5-year plans. It went into the 9th 5-year plan as well. All the while I was advocating, or rather campaigning, that we should not have a large mental hospital. Rather, we should start with so-called primary care healthcare services, where we train our primary healthcare workers, provide them some basic skills and also some medications so that they can provide the patient treatment in the patient's homes, in their own communities, that they need not be displaced and brought into large hospitals and kept there for a long, long time. So Professor Murthy's visit to Bhutan in 1999 again was a landmark in the history of mental health service in Bhutan. Two of us sat down and we had our first training of general medical doctors in the Paro College of Education. I thought it was another auspicious venue because Paro College of Education is where we train a lot of our teachers. So yes, I think teachers were also important elements of the mental care in Bhutan. So we were at least able to break in to their campus and hold a 1-week training workshop with our medical doctors. And we were basically teaching them basic psychiatric skills and some simple medications and some counseling skills so that they can at least manage, identify, diagnose simple cases, treat them in their own communities. And if they have some problem that they cannot deal with, they can call me on the phone and seek my advice, or they can even refer to me if the cases are very complicated. So that was a good beginning. But and it was good for the Burmese doctors to be there in Thimphu. So while I was moving around the country, training doctors and nurses, etc., my Burmese colleague could at least sit in the outpatient and clear some of the patients that were coming there. Yes, and again, another auspicious thing happened. DANIDA, the Danish International Aid Agency, was already in Bhutan, helping us develop health infrastructure, human resources, etc. And that was the time I approached them to give some funding to mental health. And they agreed to provide us funding for training of health workers, for doing a mental health survey in the country, and for providing some basic medicines that were required. So with their funding, I then went on earnestly traveling the whole breadth and length of the country, meeting every possible health worker and training them on basic psychiatric skills. Along with, we also then started a so-called survey, a study sort of thing. We could not launch this survey for the whole country, but we did so-called a pilot study, and we targeted 3 geographical locations in the country: Paro in the west, Bumthang in the center of Bhutan, and Trashigang in the far east. We wanted to sample some of those patients and also the people's beliefs in mental illnesses. So we devised a very innovative method of doing a survey, also providing services. So what we did was we actually mobilized traditional healers, Buddhist monks, and all other shamans in the localities. And then, of course, we gathered the community leaders. So we had extended 2-day meetings and discussions with them. The first day was basically on what are the traditional practices, what are their ideas, beliefs, what sort of cases they think they have in the communities, how they manage those cases, and how they felt whether they were able to manage those cases on their own. The second day was primarily our input. We basically gave them simple definitions of common mental disorders, such as chronic psychosis, epilepsy, alcoholism, suicide, intellectual retardation or mental retardation, and depression. So we gave them some definitions based on the scientific or DSM or ICD-10 criteria. We then asked them to nominate any of those cases that they think they fit into our 4 or 6 criteria. And then they made a list and gave the list to us. So my job now was to find out where these cases are in the community. And we train our health workers to identify those cases, not just identify, but also to do so-called KAP studies, knowledge, attitude, and practice question answers with the communities. So they visited each of those households where a case was nominated. But I also nominated another household which doesn't have a case, because if our health worker visited the community and went straight to that household which had the case, there could be a bit of a problem where the community might blame the community leaders for identifying the case because of the stigma. So having a neutral household was also nice for us to know whether the knowledge, attitude, and practices were different in the households which has a case and those households which do not have a case. That also allowed us some leeway to actually find cases who are not actually nominated or identified by the community leaders in the meeting. Again, there was so much of fear, stigma of disclosing this information. And we found out that we actually found a lot of cases in the communities who were not actually identified or nominated by the community leaders. So after a long interview with a respondent in a household, then finally the health worker will ask, do you have any of this case, of such a case in your family? If so, let us have a look. I will meet them. And if the family nominated such a case, then a doctor who has been again trained to diagnose common mental, he will then visit the household and then he will diagnose the case. And then he will alert me that they have seen such a case. And next, I will then go and I will confirm whether the case is a diagnosable mental disorder, whether the case needs any treatment. And if the case needs a treatment, I would then discuss with the local doctor and also the local shaman and the local Buddhist monk that we will now take up this case and treat it from our side, while you guys will still give the support that you are giving as usual, and we will be take over. So this is a very innovative survey method where we combined finding cases, educating the community, all the significant players in the community, training the health workers on mental health skills, and then providing treatment to them. This innovative method, unfortunately, we could not upscale it to the whole of the country because we ran short of funds after the DANIDA project finished. But this innovative project brought us 2 international awards. One came from Grand Challenges Canada, Grand Challenges, Ashoka's Grand Challenges. And we got this award in 2010 for innovative practices in community-based mental health care. We got another award from SL Foundation. That's a Vienna-based Zero Project. Zero Project is mostly on disabilities. So we've won another international award on this from Zero Project, Vienna, for innovative policies on mental health care. So with that preliminary sort of investment that I had, I was actually bent on sustaining this so-called community-based mental health care.
Fascinating. And I'm curious about the results of this survey. I'm sure perhaps it's changed over time, but what was your assessment of the state of mental health in Bhutan? And did anything surprise you about what you discovered?
So we planned in such a way that we are actually looking for chronic cases and also sort of very obvious cases, which are not so difficult to find. Most of these cases can be identified by the communities themselves because their illness has become so entrenched and the people were either dysfunctional or deviant that they were not obviously fitting into the society. We were not really looking for very subtle, mild anxiety or other disorders because it would be very difficult to find in the first place. And then, of course, even to provide treatment, we were not geared up. So those chronic psychosis and intellectually retarded or intellectually disabled, epileptic patients, alcoholism, suicide were not so difficult to be identified. But depression was an issue because depression was not an obvious cultural entity as such. So nobody knew about depression, clinical depression. And it was also difficult for our surveyors, our doctors, to really identify and confirm depression. Because depression is quite a difficult disease. because it's not so obvious outside. I mean, people are generally withdrawn, they have a depressed look, they slow down, or they become agitated. But unless the person says, I'm depressed, and it is very difficult to know whether it is really depression or something else. So we had a big challenge in really identifying people with depression and treating them. I could not leave this out because I thought that this is one disease which we need to go after and find out, because people by themselves would not even come out. When you become so depressed and you lose hope and you become helpless and worthless, you don't seek help. You seek end to a suffering, and suicide is one of those issues. So yes, suicide was, in a way, it was obvious because people knew people have suicided, although no one wanted to discuss about them because it was a taboo, it was a stigma, it was a loss, a shame for the community. But nonetheless, we dug into this, and we also explained to them that if you don't treat depression, then suicides happen in the communities. One surprise we had was with epilepsy patients. A lot of the community members did not nominate epilepsy patients, and we then found them in the communities. And the reason was the epilepsy patients actually were more stigmatized than psychotic or psychiatric patients. The reason being they believed that epilepsy is a contagious disease. So if a family, usually the families know they have an epilepsy patient in their home, but the neighbors did not know, or it was kept away from the neighbors. Because if the neighbors knew that this family had an epileptic patient, the whole family was stigmatized. The patient obviously was, because they believed it was contagious. So they wouldn't have to have anything to do with the patient. No wonder, I think the families were also protecting the patients, never letting them go out of the home, for fear that if there was a seizure, it would be known in the whole community, and then the secret would be out. So we were surprised to find a lot of epilepsy patients who were not nominated by these community leaders, who were otherwise having the seizures, but no treatment, some traditional treatment, but no allopathic treatment. And they were just suffering in silence, and also quite handicapped because they were not allowed to go out or participate in many of the social events in the community.
What was the vector of transmission that was believed to be the case for epilepsy? If I think of Sowa Rigpa, the category is sin, right? The sin disorders of contagious of diseases. But what were they proposing was the cause of transmission?
Actually, there is a basis for fear of transmission, knowing that a lot of our epilepsy patients in Bhutan, and now we have been screening all these patients on the MRI scan or MRI brain scan, and we found that something like 17-20% of them have neurocystic psychosis in their brain. Now, neurocystic psychosis is the egg of the tapeworm or the roundworms, which you ingest as parasites in your stomach. And then these eggs travel through a bloodstream, and then they get lodged in the brain and in the muscles. So, I mean, I'm talking of what we found now. I'm saying there must be a basis of some fear of contagion, to the extent that parasitic illnesses are contagious to the extent you swallow it and then you defecate, and then, so, I mean, those days the hygiene was so bad. The pigs were eating the feces, and then a lot of people were eating the pigs, which are actually infested with parasites. Although as a child, I remember that it was a taboo to eat pork, which is infested with those cysts. Nonetheless, some families did eat them because there's nothing else to eat. They were supposed to be buried in the soil and discarded. But I know some people who have dug them in the middle of the night and they would have eaten it. So there was a lot of parasitic infestations in the gut those days. But even today, it's not surprising to find a lot of parasites in people. But what those people believed in Bhutan, even now at that time, was they thought that some sort of a wild animal, maybe wild deer, maybe, I don't know, wild boar, whatever, that disease was brought by them through some of their uh, salivation, some sort of contagion. And because these people used to hunt wild animals as well and eat them as well. So then it came through them into the body. And then it spreads to other human beings through their salivation. So a lot of epilepsy patients, when they become unconscious and have a seizure, they do also salivate and foam at the mouth. And they thought those are the contagions. And that's quite a pity, because even today, when some of the children have a seizure in the classroom, and especially some teachers who are not conversant with the modern epilepsy or methods, they get scared, and they prevent the children from touching the patient rather than helping somebody when somebody is having a compulsion, has lost consciousness and salivating, and there's a real danger that the person, if left in that position, he might actually aspirate that saliva into his lungs and would cause more problems. So even today, a lot of teachers, in fear of a child having seizure in the classroom, they would actually discourage them to come to the class, thinking that this would spread around. So yes, even today, I think there's a lot of taboo about this illness, and a lot of people fear that they might get this from them.
I wonder if you might talk about this idea of stigma or taboo, and in particular how it relates to mental health in Bhutan, how things were viewed when you began psychiatric training in Sri Lanka, your practice, and also have things changed at all. Can you say more about this taboo and the stigma and the culture of that at that time?
At the time, but even today, there's so much of taboo and stigma with mental health. It is because of its anonymity or not known. I think human instinct has this way of defending yourself by keeping something away, or even consciously or subconsciously aware, even discussing this as a taboo subject. So even today, even in my own families, people used to laugh at some of them. They gossip about some of the other patients. They fear some of them. Some they ridicule them. So the stigma is prevalent even today. I don't think we have been able to do much with the stigma. But what we have been able to do now is the people are now realizing or knowing that there are now services, there are treatment services available for such conditions. And people are coming forth, even if they are coming it rather hidingly or sort of, instead of telling that they're going to meet Dr. Chencho in Thimphu, they would rather say, I'm going to go to see a general physician, but they might quietly come into my chamber and then tell me their problems. The COVID situation in Bhutan, and I was lucky, although I retired from service, but His Majesty the King called me back during the COVID time to help our people, strengthening our mental well-being. And I was able to reach out to majority of population through what we call as online, internet, mobile phones. And during that period, of course, a lot of people were in quarantine. A lot of people were having the illness. And a lot of people in their families were suffering, or rather really affected by their relatives who were suffering, or relatives who were dead. and they were not allowed to go and see the dead because of the pandemic and the quarantine measures. Some of the cremations happened without the families involved. So a lot of things were happening that time. And so we allowed people, we were connected to those quarantine facilities. We allowed people to call our counselors 24/7. And we were also monitoring through some sort of a social media apps. They can have this what you call as self-monitoring of their mental condition through some of the apps. So we realized that a lot of people were then seeking help, especially counseling, on the mobile phones, on the internet, on the social media. Many of them didn't have to show their faces. They didn't have to identify themselves. And that helped a lot of people to open up, knowing that nobody is looking at my face, nobody is identifying me as a person, but we are talking, nonetheless, we are talking on real life time. And we were then discussing those issues, and we were also helping them, empowering them rather, giving them some of the tips, how to relax their body, how to relax their mind, things like mindfulness practice, progressive muscle relaxation, breathing, slow breathing. So psychological first aid was then promoted as one of those key mental health skills that we wanted all of front runners. We had a lot of what you call as, we call them desups or peacekeepers. There were some volunteers in Bhutan. You may have heard from them, Steve. There were these orange-clothed youngsters. So we trained a lot of them on psychological first aid so that they could reach out to the public, that they become more sensitive and they become more open, and that they would close this gap, this whole taboo about the mental health. So yes, the COVID situation did help us to open up a bit, to make our population realize that everybody can be vulnerable, that there's no one called a strong man in the family or in the community. We are all humans and we can be vulnerable. Just as we'll get physical illnesses, we are also vulnerable to get any emotional disorder or even a mental disorder or even an organic brain syndrome. We are as vulnerable as anybody else. So there's no need to really fear or rather discriminate those people who do have this problem. So that situation really helped us. But going back into history, even today, my medical colleagues, I mean the specialties, the medical specialists in other departments, they have a huge taboo of mental health. And I think the main reason is because of the unknowing. None of them had exposure. None of them had training. And the training that we have in this part of the world, in the South Asia region, we are very poor, weak in psychology and mental health training. Even today, the medical colleges do not have a proper curriculum on mental disorders. So you have a generation of doctors who do not know anything on mental health. So they see it as a taboo. They see it as a very foreign element. And the stigma, I think, comes a lot from our own medical community. For example, I have been looking for candidates to pursue training in psychiatry in Bhutan for years, for decades. And I managed to get only up now at least 2 of my own initiative. And of course, in the last few years now, we have started psychiatry training in Bhutan. And those candidates, so we have 2 Bhutanese trained psychiatrists. And now we have 3 more in training. So things are a little opening up now. Perspectives are changing. But still, the majority of our medical fraternity do not see psychiatry as a medical science. They still treat us as an antiquated, archaic, sort of a mystical, sort of a subject that they either don't like to deal with or even discuss.
You've said there that in the South Asian countries, psychology and psychiatry training is weak. Why do you think that is?
So it basically stems from what Maslow, the psychologist Abraham Maslow, he devised this hierarchy of needs for human needs. And, in that pyramid, we have at the lowest the food, shelter, and clothing. And then we have the next level where we need some security, protection from fear, protection of your rights. Then we have some, needs for knowledge, prestige, some sort of perks, some sort of specialization. And then we have at the tip, self-actualization. So in many parts of the world, especially in the third world, and we've been here in South Asia, our preoccupation with life is still at the bottom, the rock bottom, Maslow's hierarchy of needs. We are still talking about food, shelter, and clothing. There is a very apt Hindi film, a Bollywood film called Roti, Kapra or Makan. Roti means food, Kapra means clothing, Makan is shelter. And that movie actually is a very old movie that really depicted what is life in some of the poor countries in the third world. So even in Bhutan, I think our people are primarily preoccupied with survival. And we are in a survival mode with survival instincts. So telling somebody, I'm not feeling happy, I'm not feeling pleasant, it's a luxury. It's a luxury. You don't have the luxury. I'm feeling hungry. I am ill. I'm having pain. I cannot do the work tomorrow. I cannot complete that work. I can't do those backbiting work. That is a concern for everybody, because if you can't work tomorrow, then you might land up not eating tomorrow because you may not have the food. So I think civilization-wise, I think people in that part of the world are bent on survival mode. So, not feeling happy, not feeling pleasant, I'm feeling cold, I'm feeling hot. All these are sort of luxuries that you can have once your basic needs are met. So even today, if you are complaining to a household, to the family, or to friends, or to your spouses, that I'm not happy, they will not take you seriously. They think that you are a bit of a narcissist, that you don't understand the reality of life. The reality of life is you have to survive. Those are not survival skills. Survival skills are just living and surviving. So even today, if you go and see a patient in the hospital or at home, you would invariably tell the patient, please eat well. Please eat well. Because if you don't eat well, that is a sign that you will then deteriorate and you will not probably survive. That may also come from many of centuries of civilization where there's no treatment. So eating is a must if you are ill. If you don't eat, then probably you'll not survive. So even today, when you have so much of sophisticated treatment in the hospital, it looks very absurd for somebody to tell a cancer patient who is having a cancer of the throat and maybe having a Ryle's tube in your nose and then some intravenous drips, people will still say, please eat well. Please try to eat. try to eat. Of course, the person will try to eat, but he can't. But this phrase still holds very true. And that is a testament to the fact that we are talking about survival skills. We are not talking about luxurious things like, are you feeling hot? Are you feeling cold? Are you feeling comfortable? Are you happy? Are you sad? So those terminologies are even not so much in the vocabulary or in the vernacular. People are not used to addressing or talking in those terms. Of course, today, we are catching up very fast with the world. And I think our youngsters are much more, I would say, vocal or emotional. For example, there is a personality disorder called borderline personality disorder. Did you hear about it, Steve?
Oh, yes.
Yes. When I was a young psychiatrist in Bhutan, and for 10 years, I thought I never saw any borderline personality disorder in Bhutan. Then I had a young colleague. I found a young lady who was interested in psychiatry. Either she was interested in psychiatry or she was impressed by my charisma. I asked her one day, do you want to become a psychiatrist? No, no, she said. I said, why? I'm afraid of psychiatric patients. Then I asked her, what are you going to do in your future specialization? I want to become a pharmacologist, she said. I said, why pharmacology? Oh, pharmacology deals with medicines and this and that. I don't have to go in the middle of the night and to do an operation or in the ER. So as a lady and as a family woman, I would prefer that job. Oh, if that is so, I said, psychiatry is the best for you. Because, why? If the patient wakes you up night, you tell the nurse, jab one injection, the patient will sleep. You don't have to wake up in the night. They will take care of it. Don't worry. But I'm still afraid of the psychiatric patients. No, there's something called desensitization in psychiatry. I will apply this technique on you and I will desensitize you. So she went to Israel and she did this 4 years MD in psychiatry. And then she came back. And then she started diagnosing everybody as borderline personality disorder. But I said, well, when we go to the medical college, we have something called a third year syndrome. Third year is when we start going into the hospital, hanging a stethoscope and wearing a white apron. And we feel like as if we have become doctors because now we have the garb of the doctor. We are quite proud, quite ego, and we learn a lot of clinical stuff. And every patient we see, we talk in earnest and come home and start esculting our own heart and lungs and start diagnosing ourselves. And we say, I have this problem, I have that problem. So this is called a third year syndrome. But yes, by the time she graduated, I'm talking about 2015. So borderline did come to Bhutan. I mean, she was enthusiastically just diagnosing everybody because she probably saw a lot of borderline in Israel. But that was not the case that they were all borderline. But by 2015, borderlines have started coming to Bhutan, coming to our OPD, to our clinics, to our hospitals, mostly because of self-harm. Ladies cutting themselves, threatening suicide, even overdosing and trying something, all this strangulation. Young people, young men, young teenage boys taking drugs. I think the drugs is also one of those issues with borderline. So we now started getting a lot of borderline cases in Bhutan. And it has become quite a headache because for one, borderline, the mental health people have a different attitude. Oh, this is a trait, this is a personality issue. Why should I be bothered with it? Second, we are not well prepared or trained to deal with these people. But nonetheless, they are irritating, they are annoying. They are trying to harm themselves. They're trying to kill themselves. You might lose them in your hand. So it's become a big, big challenge. But I am now saying, I don't think that borderline personalities were not prevalent in Bhutan at that time when I started psychiatry in Bhutan. There may have been a few cases, but of course, the numbers have doubled, quadrupled many times because of the social changes in Bhutan. At that time, when there were borderlines, first thing, the borderlines don't happen because, as I said in our last talk, when you live in a community, and the community knows everybody, the family knows everybody, the whole community is like a large family, and the demands of the community and the atmosphere were more or less the same and homogeneous. There were not many challenges. There were not many so-called single families, not many marriage breakups, not many drug-affected parents or people. So there were no need for young people to become borderline in the first place. Even if they are borderline, the social safety nets, the support that they have, wouldn't have allowed them to manifest the symptoms that we now see today. But today, and I'm talking about 30 years backwards, when Bhutan opened up its doors, we had this rural-urban migration. Some of the houses in the rural places are getting locked up. We call it gungtong, locked up. Now today, some people are even saying, we're going to have the towns locked up. People are migrating outside, exodus to Australia or Canada. So when people started congregating in the towns, and then we have these nuclear families, we started living in these apartments, and then we don't know our neighbors. We don't even speak to our neighbors. We don't even know what they are doing. If they are fighting in the middle of the night, we wonder why these people are doing that. Should we call the police rather than go there and help what's happening around? All these were happening in our societies, in our towns, 30 years. And now we have now a generation of young children who, when the parents are either glued to their televisions and not looking after the children, or the fathers are alcoholics, so inebriated every day, or they're beating their mothers or the children, where do the children go? The children will end up in the streets, because there were no extended families. There were no communities to look after them. They land up in the streets. They learn from each other. They gang up. They learn how to take drugs. And then they manifest in all sort of dysfunctional, deviant ways. So today, we have unfortunately caught up with the modern world, or what do you call as the Western world, in terms of having borderline personalities among us. And they are part of our everyday clientele in our psychiatric OPDs and even in our wards, where we need to diffuse the tension sometimes. We need to give them some respite, not just to the patient, but to the families, because they keep on fighting, they keep on threatening, they keep on harming themselves. The families get burned out. So yes, I think now we are at this stage where we are still living with some of those issues which you are not able to handle since time immemorial, but you're also embarrassing what the modern, so-called modernization, urbanization, all these are bringing forth. For example, just last couple of weeks, I have been getting some young men and women in their 20s, early 30s, who were not functional. Some were deviant. Some manifested some psychotic symptoms, but the families were not aware that they had mentally ill. And then they did something or other that attracted the attention of police. And the families and their relatives and their neighbors reported the police. and the police locked them up in jails. Some of them were even convicted and landed up in 2-3 years in jails. And now our judicial system, because our judges are also now modern educated. The police are now getting modern educated. So now they at least have a consideration that if somebody is repeatedly doing something, is it because do they have a mental illness? Or is it just because it's part of their personality? Is it a state or a trait? And then now they are sending the patients to us for assessment. And we are finding that a lot of them did have chronic psychosis, but they were not treated. And then they behaved deviantly, and then they became aggressive sometimes, and they become unpredictable. And then they were dubbed as, socially misfit, and some of them are convicted. So yes, on the one hand, we are living with those unmet needs of people who genuinely needed early treatment and get on with life, just like my brothers. But on the other hand, we have now a new age issues such as borderline personality disorders, which are a handful to deal with, and not necessarily easy to handle as well. And the worst part is most of them do not attract the so-called compassion that they deserve, actually. I mean, they're not acting out. Well, they seem like they're acting out, but it's part of their mental faculty. And most people will view them as acting out. It's part of their behavior, and rather not treat them well. But they also need understanding. They also need help. So we are now grappling with, both traditional psychiatric problems and also what actually happens in the rapid urbanization, in the rapid so-called modernization. Now, with modernization in Bhutan and urbanization, there were obviously economic development, and there were a lot of progress. There were a lot of progress in material achievement. We have some nice big houses, we have big cars. Our lifestyle has changed, and in many places it's as good as in Western civilizations. But that also has created a big rift in the haves and have-nots. So some people advanced so far, but a lot was left behind, and those people felt the need to become like the others. So there's so much pressure again to try to catch, and it's become a bit of a race. And when you do have these races, obviously the weak ones will fall apart. And that again is a major social issue. I remember Anil Durkheim, the French sociologist who wrote his book, and he was in the mid, I think in the 19th century, when there was the French Revolution and the Industrial Revolution, and all the people started migrating towards towns and cities and industries. And then there was, of course, progress in terms of economic development, but there were a lot of other people who fell in those crevices, in the abyss. And then there was this rise in suicide. So yes, even in Bhutan, I think as we progressed, even when we have this gross national happiness and all the other principles in place, but then the race began, and of course, many people did very well, but some of us do not do well. And there's this now modern word called FOMO, the fear of missing out. Now that's also driving a lot of people crazy. So just because your neighbor is going out, you must also go out. And I think there's a lot of stress and strain, and that is also one of the causes of mental health, especially stress-related disorders like anxiety and depression.
Very interesting indeed. You've mentioned the modernization of Bhutan and the effect it's had on community, and the effect of the fragmentation of the community on mental health. I'm curious about the role of religion and religious authorities. If I think about similar sorts of processes that I've read about or seen in other contexts, sometimes that religious dimension does provide mental support, and in fact even religious professionals, priests of various types, can provide a pastoral role, a kind of counseling in a sense. And it sounds to me like many of the things you're training your medical workers to do, psychological first aid as you called it, overlaps perhaps a little bit with what I at least imagine, because of what I've seen elsewhere, religious professionals. It might be their turf a little bit. How to improve your mood, how to care for the soul, how to release stress, how to, dealing with existential issues and so on. So I wonder about that. I'm curious about the role of religion in Bhutan, what its function is, and has it changed? But I'm also curious, is there overlap in terms of the territory of what you've been doing and what the religious systems have been doing? And if so, how has that meeting gone?
This is a very important question, Steve. Bhutan is still very, very religious, I would say. Buddhism is quite prevalent, or rather pervasive, in the day-to-day life of the people. Bhutanese claim that Bhutan is the last Vajrayana country in the world. I look at Buddhism in three ways, Steve. I look at Buddhism as a philosophical way of life, as a spiritual practice. I look at Buddhism as a modern science of the mind, where we have these mindfulness practices. And I look at Buddhism as a religion. Why I'm saying that is because what I understand Bhutan is majority of the people look at Buddhism as a religion. Along with that, we also have this shamanism or Buddhism, and Guru Rinpoche and other religious leaders who came to Bhutan, Shabdung Rinpoche and others, they have thoughtfully considered and kept some of the shamanistic rituals as well as part of the Buddhist rituals. So again, now there are two rituals going on side by side. One is the Buddhist rituals, the other one is the Bon or the shamanistic rituals. And quite often they even intermingle or even contradict each other. But when somebody becomes ill, both forces come into being, and people spend hours and days and months doing those rituals, day and day on in the end. I know from my own family experiences, and rather we are a bit burnt out, I should say, that we did so much of those rituals, and we are basically burnt out. And we realized that the rituals didn't help my brothers. They didn't help my mother. What they needed was really modern treatment, some antipsychotic drugs, antidepressant drugs, and of course, support, family, community support. As a psychiatrist, as a Bhutanese born in Bhutan, and as somebody living in Bhutan, I live with this everyday experience of Buddhism and its religious practices all around me. But somehow I don't really invest a lot of my time in those, although my family would like to do. For example, my in-laws does a ritual practice or a ritual ceremony almost every month, almost every week. I just become part of them. I never really invest much emotionally into this, because I think that I have a lot other things to do Why should I also join the bandwagon and do this when I can do other things, but other people are not doing it, or they can't do it? But I am a minority in this area, and I don't voice my opinion openly to challenge or even debate or get into a discussion, because there's no point. It's just waste of time. So we just have to go with the flow. I try to engage our religious practitioners and our traditional Sowa Rigpa practitioners in modern mental health. And to a large extent, especially Sowa Rigpa, we are now succeeding. It's been almost, I would say, 20 to 25 years now that I started engaging with them. So finally, we have a small unit in my department. We have a Sowa Rigpa unit in my department. My patients don't have to go all the way to their hospital. The unit is in my department. They have all these applications. They have moxibustion, ball needle therapy, acupuncture, steam therapy, all other therapies, including Luzhong and Shine, the shamanta practice and yoga practices. For example, the Sowa Rigpa traditional practice in Bhutan has now come up with 32 yoga practices, out of which 8 of them are specifically for mental health. It was not there when we started all this, but in the last 10 years or so, they are also coming of age. And they started researching, and then they started doing those. And they are now promoting all over the country. Steve, when you come to Bhutan, you might have even noticed Sowa Rigpa and modern allopathic medicine are provided side by side in all our hospitals in Bhutan, except in Thimphu, where they are separate 2 large institutions. But everywhere else in Bhutan, you can find the Sowa Rigpa practitioner and the allopathic doctor under one roof. They have their own pharmacies, they have their own treatment methods, but they do it together. The only thing that what I wish would happen was that they work more closely, that they discuss cases together, that they refer cases to each other so that patients are not confused, so the patients get the best of each of them. That is not happening. That's what I wanted to happen. So I started inviting Sowa Rigpa doctors to our psychiatric clinic or psychiatric ward rounds every week to teach them about modern mental health. In turn, I wanted to go over to their place and learn from them how and what they do. But we were never invited so far. I'm just thinking that they're not confident enough to even get us there. I don't know the other reasons. I think probably they're not so organized. I don't really know why they are reluctant to get us. We are open. So that's the reason why they're in our ward. So they give meditation practices, shamanta practices, teaches to our patients. They're giving these yoga practices, and they're also giving these alternative treatments. So Sowa Rigpa and traditional forms of treatment has a role in modern mental health services. I think we discussed a little bit in the last session as well. They are particularly effective, I think, in the chronic syndromes, chronic pain syndromes, so-called somatizing syndromes, where the modern medicine is not very effective. We can give all the painkillers, but the more you give painkillers, the more the body gets affected because of the side effects. And also the practices are much more culturally or user-friendly. They're not as invasive. They are not as aggressive as we are from the allopathic side. Now the Buddhist monks. So in Bhutan, again, as you have already probably aware, Buddhist monks are organized in so many ways. We have institutional monks. We have lay monks in the villages. We have monks who are practitioners in the retreats high up mountains. The monks are coming up with their own ways and means of reaching out to the young population in Bhutan. For example, some of those clever, smart monks are really reaching out to the communities to teach them some practices. Because in the good old days in Bhutan, religious practice was the domain or the privilege of monks, not lay people. Lay people would retire towards the end of their lives into retreats and stay in those retreats, and they basically chant some mantras, but they don't do any really sophisticated meditation or practices. But now I think the monks are reaching out to the younger generation so that they empower them to also now understand and let them practice. The monks, again, is a traditional practice. As you know, Bhutan was a theocratic state. So they ruled Bhutan for centuries. They devised ways and means how to control the people, how to collect taxes. I actually said they are very clever, actually. You know what? They start collecting taxes even before a person is born. And they start collecting taxes even when the person is dead. You know what? Even before you're born, you go through all these religious procedures and practices, and you pay the monk. And then you're born, and they're happy. You have celebrations. You pay them, and all throughout, of course, you pay them. And when you're dead, they do all the death rituals, and you pay them. Another very clever device they had. They didn't have much prisons those days. They didn't have policemen. They were controlling the human mind. They didn't have to have policemen to watch them. They didn't have to put people physically in the dens to punish them. They used skillful means to control human behavior. So I see enormous potentials in the religious or the ways of how we can use this in mental health. I'm just basically saying a small bit of what I understand. There are enormous potentials. But I, for one, to get to their level is a bit difficult for me, really, to get to them, knowing that they are already quite enlightened beings themselves, and how best, I would be able to sort of mold or use their skills or knowledge and practices for ordinary beings. But that said, Buddhism, as Steve, you know, is a good religion, but the Buddha said you have to practice yourself. You are a Buddha yourself. Buddha can't do things for me. Buddha can teach me how to do things. So I'm wishing that rather than my patients waiting for a Buddha to come and tell them, this is the way to, that he will send you to salvation or something, that the monk or somebody will come and teach our patients how to practice. So not just for improving their mental health and well-being, but also to get enlightened. That's the ultimate wish for every Buddhist. So I find it a bit difficult in this stage or age where our patients, most of them, are one step behind. I just wish they were in the front line and ready to receive the teachings and the blessings from our monks and from our enlightened masters. But unfortunately, as Dr Chencho Rinpoche frequently says in his teachings that if you put a teacup upside down and you pour as many good teas on it, it will never be retained. It will only be wasted. So again, going back, you also need a bit of the karma to be able to be in the receiving end, to being open. I think this word open, as I start getting older, is becoming a very important factor, especially as I deal with so many people with substance dependence, alcoholism, even gambling or internet. Majority of them are not open. I mean, from the scientific perspective, we say that our ego defenses, but if we are not open, then it's very difficult to do anything. So that openness, where do we have this openness? Many of my patients, unfortunately, are not in a position to be open.
Very interesting. You mentioned the rituals, the exhaustive rituals and supernatural means that your family went to, particularly for your brother Nima. We discussed that in the last episode, and you referenced it here again. And you also mentioned that they did not help your brother, and that they exhausted your family in the process too. Sowa Rigpa, or traditional, supernatural as you called it, view of mental health. They'd said, for example, one of the ideas was that perhaps your brother's soul had been stolen by a female spirit, a protective spirit of the area, powerful protective spirit. So your family was trying to get his soul back. Of course, this model, this view, quite different compared to modern psychiatry. A traditional practitioner might say, well, there's an infestation of spirits, or there's some sort of agitation, dawn provocation here, there's some loo or something that needs to be propitiated. That's why you're having the symptom. And the psychiatrist would say, actually, it's biochemical or something like that, or it's related to trauma, or whatever the case may be. And they can't both be right. Or can they? Maybe they can. So how do you navigate that? Have you had to go to a situation where a traditional practitioner is saying there's spirit possession happening here, and you're saying, no, it's biochemical imbalance, or it's psychological trauma? That kind of clashing of ideas, of diagnosis, and of methods, and perhaps even of worldviews, I can only imagine that could cause conflict. Perhaps that's just my imagination, it doesn't happen. But I could imagine that kind of a fundamental difference in approach and worldview there might be conflict there. Have you experienced that, or has that not been the case?
Oh, well, I experience this every day. Every day is a challenge. The only good thing is I offer my services with the best hope that, given my limited knowledge and experiences of modern science, so I give this with an open heart. But my patient is a different person. The patient is not me. The patient is made of many other stuffs. And I very well know what is going on in the back of their mind. What I'm telling them is only one part of what they will receive. They would have received 10 more things from other people, from their own families, from their monks, from their shamans. I'm only one part of it. I have to also live with this expectation that I'm just one player and not the main player or the primary player. It also gives me a little bit of sort of solace that I'm not pushed to my limits to provide everything for this person. I was relating to you some of the incidences I had in Australia, for example. In a Western society, you are the sole provider. That's where the buck ends. And you are pushed to do something, even if it's to find a new novel medicine and push this on a patient and try, you'll do that. I'm not pressurized to do that much but I can do my best for my patient. So I have this joke. Our patients, let's say a bipolar patient with a manic episode gets admitted in my ward because the patient has become unmanageable at home because they're shouting, they're speaking, they're singing, they're dancing, they're doing all sort of things. Invariably, they will claim to be a Guru Rinpoche, Guru Padmasambhava, if it's a male, and if it's a female, they'll think she is a Hisheshogel. So there are tendrums and, so they are in the ward for a week. We allow them to be tendrums and Padmasambhavas, so long as you are not going to manifest your powerful influences over other patients, so long as you are not going to go on a blessing drive, so long you are keeping up to your bed and you are giving your sermons, that's fine. We will give you the medicines and you keep on doing that. And it takes about a while, maybe a couple of weeks, for the Khandrum or the Padmasambhava to go away, and we take it as part of our life. The sad thing is, after a couple of weeks, we then finally send the patient home because the patient's condition has stabilized. And then we want them to continue with the medicines. Some of them are mood stabilizers. The sad part is, invariably, in that period of time, they would go and meet a monk or a traditional teacher or a healer, and they will do the rituals. And who claims? Those people who claim the results, because the people believe that they were healed by those by the treatment providers rather than us. We are more of a menace in their lives because we took them away from the homes and let them not practice what they did in their homes, and rather took them away and rather incarcerated them in our wards, which are not the best places they want to live. So we are looked down more as so-called infiltrators or distractors. But we know what we are doing, and we know so long they are taking our medicines, we don't really care what else they do. And fortunately, time tells, and results do impact, if not the patient, but at least their families, because families have difficulties managing them at home when they are wild, manic, and violent, and they know that our medicines does help. Even if they have other beliefs like, yes, other things may influence, but at least we say, you do whatever you like. We are not there to comment or encourage or discourage. What we insist is that you have to take the medicines and that you have to keep in touch with us and that you make sure that you take the medicines, you will remain well. I have many interesting stories related to religion and our interface. Maybe I'll just relate to you one or two. So there was this community, there was a far-flung community in Bhutan where there was this belief that a child was possessed by a dead person, a child. This child was a very charismatic, quite a pretty girl, around 15 years old. In one of those remote schools, it's not a high school, it's a junior high school. So she was probably the eldest in the school. So one night, she got possessed by a dead person's spirit. And soon, other children started getting possessed by the same spirit. And then 13 children got possessed by the same spirit. And then the school was shut down because it became a bit of a problem managing the school. All the children were sent home on a vacation. I was monitoring the situation from Thimphu. The local doctor was visiting the school and then just watching and just reporting to me. Now, this is what it's called as a mass hysteria, so-called community, mass hysteria of possession states. So the local government and the doctor and other people are all doing what they can So basically, they're using the religious means to quell this possession state. So they have done some rituals, and it went on for 2 weeks. It was not working. So finally, this doctor was saying, maybe I think I should come and visit and see what is happening there. Well, he also got scared. And the local government leader also got scared. The head teacher and teachers got scared because the teachers were more scared that that devil might enter the children's souls. And they also got scared that the devil might come with them. So finally, it was my turn. And then I sought the help of the education director, because he was a bureaucrat in Thimphu. So, something happening in the school closed down. The bureaucrat should be, I mean, I don't have much authority when it comes to administrative matters. I can only see patients and give them treatment. So I asked him to come along with me. So we went. It's a day's journey, and we arrived there. It was a very far-flung, very remote, quite a deep inside the jungle, near two big rivers. And the rivers were making such big noises. You can feel the whole atmosphere with the beating of those things. But then we also heard some faint noise of religious rituals, bugles being drawn. And then I was telling the director, all right, now they are doing some rituals. Yeah, they're doing some rituals again. Yes, it was right. We arrived at the scene. The rituals were complete. But this time, the ritual was a very dramatic ritual. It's called an exorcism ritual, where you have this big mass fire drills, and you're basically chasing the devil out of the school. I went with my audiovisual equipment, hoping to just capture some of those possession states, and even interview some of the parents, because the parents were also gathered in the school. The rest of the school were not there. It's only the children who were possessed, and the parents, they were brought in the school on that day for the ritual to drive them there. So the ritual was over, and I wanted to interview each of the children. I interviewed them, and they all said yes. There was a white lady, long hair. I didn't see the face, sort of white cloth. And then I asked the parents, when the children came home, did this ghost enter them? It never happened in the school, in the homes. It only happened in the school. Okay. Now, do you think that, I'm asking the children, do you think this ghost will come back to you? The children said no. Each of the children said no. I asked the parents, do you think the ghost will come back to them? No. No. And I asked them why. Nobody was able to tell me why, but I knew why. Because that day they did this exorcism ritual that drove the spirit away. Earlier, they did some rituals, but they didn't do this dramatic ritual. So again, and of course, education director decided to stay in the school that night to give moral support to the teachers. I returned home to the local hospital to talk to the doctor. And surprisingly, there was another girl admitted in the ward there who saw a devil. And she was possessed by the devil, but in a different school, in a high school. But because it's a high school, somehow they just brought this child to the hospital. And they have given her some sedation, so she was a bit drowsy. So I told the doctor, from now onwards, if there any child who gets possessed by a devil, separate them from the school, bring to the hospital, give them heavy dose of sedation, and let them sleep, and not let them have dramatic influences over children. That is the solution. So, of course, that sort of episode didn't happen after that episode. Not that I did anything in particular, but that's how so-called a traditional form of treatment can also deal with sort of a mass hysteria of devils. In the same area, I mean, that area is, people have a lot of superstitions. So one day, a hell worker's son got possessed by Lord Shiva. So he started behaving like Lord Shiva. He was a school student. He was in class 5 or 6. He was around 12 or 13 years old, and he started behaving like Shiva. He wanted absolute cleanness in the household. And he was a hell worker, the father. And the word spread around in the community, the local government, the local lama, everybody went and recognized him as one of the reincarnations of Shiva. So this went on for a few months. Then there were a lot of people visiting them, retinues of people coming for seeing the Shiva. Then one day, his elder brother, who was in a boarding school, came home for the vacation, for summer vacation. And after a few days, the elder brother got possessed by devil. Not Shiva, devil. Now the devil and Shiva started fighting in a house. And the father had so much difficulty separating them. And word spread around now that there is another devil in the house. And the local government and the monk, and then they had some reservations about this family. How can the devil and the Shiva can both exist in the same household? That was the time when they decided to send the patient or the child, the two boys, to me to Thimphu. When I saw him, the hell worker came with a shaman. And I asked the hell worker, why did you bring the shaman to the hospital? Because I expected the shaman to do rituals at home, but we can't do shamans in the hospital because this will be too disturbing for other patients. And the hell worker is a clever man. He said, normally we hire shaman for one night, but this time I hired him for a whole month. I said, why did you have to hire him for a whole month? Because I need help at home. Every night they are fighting. So I catch one and he catches another. So shaman was doing a completely different job. Interesting bit. But I did ask the shaman, how do you use your influence to really get these two people separated? Because I believe they're fighting every night. Oh, yes, sir. I'm losing my my power of influence now. I'm just also scratching my head. I'm hard of now methods to. So one night he said, I did a wonderful thing. I said, what did you do? I threw them hot boiling water over their heads when they start fighting. And they separated, he said. I said, that's wonderful. But why didn't they scald their heads? No, because of my power of my deity, he said. I asked the father, who's the hell worker, did he really throw hot water on the boys? No, sir. Out of his confusion, I think he threw some water from the thing. And I think that shocked the children and they separated. So obviously it was not a very boiling water. It was some water. And I didn't keep them in the hospital. I just gave some mild sedatives to both the children. And I told them that now that your local government, your lamas are no more recognizing your status. Now you can't behave and act like one. You have to now follow your whatever that you are doing before. Both of you are students. So now think about going back to school and start preparing yourself mentally for that. You just can't now be Shiva and the devil. That's not allowed. I don't believe in your miracles. I'm a modern doctor. I'm a scientist. I don't get scared of those deities. I'm challenging your shaman here. So I don't subscribe to such behavior. I'll give you those medicines. You come after 1 month. I don't want those garbs. So the Shiva was almost dressed like a sadhu with all the rosary and the thing. I said, next month, you can keep some rosary inside, but outside you have to wear your traditional, clothes, and you have to come and see me. Of course, they never came back. And I think they were all right. They probably went back to school. But I mean, that sort of things happen in our society. So it's just a matter of how we really negotiate and basically understand what is really going on in their mindset. And rather than challenging and butting your heads, finding a way out of it. And I think that also requires a little bit of understanding the culture, the beliefs, and the traditions. So that's why I think psychiatry is so much to do with what people believe, what people do, and not so much with what a psychiatrist know or do. Because if you don't share the belief system or the practices or their habits, it will be very difficult to cross over those barriers and reach out to the core of the being and help that person.
Fascinating. Thank you. This has been a credible conversation. Thank you for sharing all the stories and experiences. My last question to you for this interview is, what do you see as you look into the future? The direction of mental health and psychiatry and so on in Bhutan. What do you think the challenges on the horizon are, and what are the opportunities, and what direction do you see mental health care moving in Bhutan in the future?
We are lucky. Her Majesty the Queen, Gyalpo Jitinpema Wangchuk, has taken interest in mental health in the recent years. Not just mental health, but also looking after children and women. So protection of women and children, and substance use, and mental health. So these three problems are so intertwined. We cannot actually do with the other. I mean, you can't just look after mental health and not forget about children upbringing, parenting programs, and dealing with substance use. So we have a lot of hope in Bhutan that with Our Majesty's blessings and patronage of, we call it Pema Center, derived from our name, and also Padma means lotus. The symbolic, metaphorical meaning of lotus is the lotus grows from muddy, dirty source water, but the lotus grows into a beautiful and very fragrant, and where all the celestial beings sit on that. So that is the metaphorical meaning of Pema. So under her aegis, we have now started building a 60-bedded so-called Padma Center, where we have the state-of-the-art mental health services, both inpatient and outpatient, in Thimphu. And of course, the rest of the countries, like I said before, this Padma Center will be a backstopping, a training, technical backstopping, training health workers, finding resources, doing those sort of research that is required. So we are very much hopeful that with this initiative, that we'll be able to consolidate on some of the work that I have been doing in the past. There are still so many unmet needs in many far-flung areas of Bhutan where patients are not identified, not treated. But on the other hand, in the towns and cities, we have this surge of youngsters with borderline personality disorders, with substance use, who are threatening suicide, self-harming. So the challenges are much, much bigger now than when I started as the psychiatrist in Bhutan. We are now 6 psychiatrists, and Many more will come in the next few years. But our challenges are much, much more than I could even imagine at the time when I started. So it's going to be a huge challenge. Mental health is going to magnify more and more as we, as a society, try to progress around the so-called modernization, which basically means economic achievement or modifying our living styles. We are becoming more obese. We're eating more, doing less physical exercise or work. Lot of substance use, alcohol are coming in our society. People are traveling around abroad, but coming back stressed out and broken with breakdowns. Elderly people in the homes in Bhutan are living left to themselves. Some of the active members have left. So it's also now time for us to really plan how we're going to look after even the elderly population, because our population are also aging. Our lifespan has become 72 years now. A lot of people are living beyond their 80s. So we also have to start planning how we're going to look after those old people. So there's a big role, as you say, even our religious community, to come forward and play some of those important roles that they always played in the past. But in the recent years, I think they have lost a little bit of touch. They need to also remodel themselves, reformulate their approach, and be more proactive in providing services to the community, and not just sit and expect people to come and get their blessings or teachings, but rather be social workers on the ground, reaching out to people with mental health issues, people with substance use issues, elderly people who are not well, who are lonely. So I think the challenges are much more than we can expect. But we hope that if we, and with our leaders, His Majesty the King and the Queen behind us, and we put our full heart and effort in that, we can overcome many of our challenges and perhaps show as a model to other third world countries, other poor countries, what sort of a mental health care that a poor country can provide. Bhutan can show this way, because most countries in the developing world do not have a mental health care service in the primary health care as such at this stage. If they do have a service, most of them are only medical oriented. That means dishing out only medicines. We in Bhutan, we have started training clinical counselors. They're not clinical psychologists. Clinical counselors are undergraduate 4-year course. They are trained not to prescribe medicines, but to talk to patients. We have specifically trained this cadre because our doctors are not talking to the patients. They're only dishing out drugs. We need another cadre who will talk to the patients, who will educate, explain, teach basic skills like slow breathing, relaxation, mindfulness practices to patients who are having anxiety disorders. And these counselors are then now posted to all the district hospitals. And hopefully in the future, as the numbers increase, we're also hoping to place them in the primary healthcare centers so that the patients have both medicines as well as therapy in that community center, which will be a model in the third world. I know some of the developed countries do have that, but most third world countries do not have those services. So Bhutan may well be a model for such a integrated care, mental health care at the primary health care level.
Dr. Chencho Dorji, thank you very much.
Thank you for having me, Steve.
Thank you for listening to another Guru Viking podcast. For more interviews like these, as well as articles, videos, and guided meditations, visit www.guruviking.com.